diseases in social and preventive medicine. So starting with chickenpox and measles. So it's a very important differential thing. Chickenpox is caused by varicella zoster virus. The peak age this disease is going to occur is between 1 to 10 years, mostly between 3 to 6 years of age. The incubation period is between 10 to 21 days. Of course, the median range will be 14 days. So it's like 1 to 3 weeks and 2 weeks, that's the median range. And the mode of transmission would be chickenpox, measles. Both are transmitted by airborne route compared to droplet infections. It is by airborne route. The period of communicability for both for chickenpox, it is 1 to 2 days before the onset of rash, and after the onset of rash it is 4 to 5 days after the rash. So isolation period should be after the onset of rash we diagnose that it's chickenpox, and the patient should be isolated for at least 1 week or till the scab is getting formed, non-infective form rashes formation. Secondary attack rate is also there, 80 to 85%, and the fatality rate is very low, less than 1%. And rash is a vesicular rash. It appears first on the trunk. Complications would be, suppose if the patient is immunocompromised or if the patient is a neonate, that leads to pneumonia because of varicella zoster. Or if the patient is very early and is pregnant, that leads to congenital varicella syndrome. So the congenital varicella syndrome has features of microcephaly, micropnea, microophthalmia, low birth weight, limb atrophy and deafness. These are the complications of congenital varicella syndrome. So the vaccines for chickenpox is a live vaccine, Oka strain live vaccine. Dosage, it is given subcutaneous route at 0.5 ml between 12 to 18 months, between 1 to 1.5 years of age. 2 doses are given, less than 12 years, 1 to 3 months apart. If the child is more than 12 years, it's 1 month apart. So the vaccine protects the baby for at least 10 years. Because the strains are getting changed, the vaccine can protect only for 10 years, and even if a different strain comes, the attack rate is also high. Going for measles, measles is caused by measles virus, which belongs to a single stranded RNA morbilliform virus. A single stranded RNA morbilliform virus, and that belongs to the family of paramyxoviridae. The peak age for measles would be a very small age group, just 6 months to 3 years. That's the age group for measles. You can remember it by the time that we give vitamin A administration, because vitamin A deficiency is commonly associated with measles. And the incubation period for measles would be like almost 2 weeks, 10 to 14 days. Similar to chickenpox, airborne route is the most common than droplet infection. Period of communicability would be before the onset of rash, 4 days before to 4 days after the onset of rash. It's just a force. 4 days before and after the onset of rash, and you have to isolate the patient till at least 1 week, 6 to 7 days. And the secondary attack rate is also higher as chickenpox, 80 to 85%. Measles fatality rate is very low. The other features would be high-grade fever. You'll be having a maculopapular rash as opposed to vesicular rash in chickenpox. Here you get a maculopapular rash and mostly starts in your postauricular region, whereas in chickenpox it started on the trunk. But here in measles it is starting on the postauricular region and in the face. We have 3 C's of measles, that is cough, coryza and conjunctivitis. And other things would be the patient be having diarrhea, the baby would be having diarrhea, malnutrition and vitamin A deficiency. Complications, when it goes to complications, we have otitis media, and it can go to the brain. That can cause subacute sclerosing panencephalitis. Subacute sclerosing panencephalitis, but it's rare, but it is specific for measles. And the most fatal complication of both would be, because it is airborne, pneumonia. You can think of pneumonia. Extra thing would be otitis media and subacute sclerosing panencephalitis. The vaccine of measles is, we have measles vaccine, which is also a live vaccine, and the strain of it is Edmonston-Zagreb strain. Edmonston-Zagreb strain is a strain of the live vaccine of measles. You have again the same dosage, 0.5 ml subcutaneously given at the right upper arm. It is reconstituted in distilled water and it should be used in 6 hours. There is no open vial policy for measles vaccine. And the stabilizer is a gelatin and sorbitol. Because of these two things, gelatin and sorbitol, there is possibility of allergic reactions after measles. Once we get measles, treatment is by antibiotic. The most important one is neomycin as compared to erythromycin. Neomycin is a better antibiotic. Schedule, it is given as per the schedule, universal immunization program. We have 2 doses, one at 9 months and the second one would be 16 to 24 months. And the maximum age check that should be before which should be given is 5 years. This was all the difference about chickenpox and measles. Both are caused by virus, varicella zoster virus, morbilliform single-stranded RNA virus. Peak age will be within 10 years, 1 to 10 years, it's within 3 years, 6 months to 3 years. Incubation period is almost 2 weeks and it transmits by airborne and droplet. The communicability for chickenpox is before the rash 1 to 2 days and after the onset of rash 4 to 5 days. Whereas in measles it is 4 days before to 4 days after. Isolation period should be 6 days after the onset of rash in both things. Attack rate, secondary attack rate is higher, 8 to 85%. Fatality is lower. You get vesicular rash in chickenpox, whereas you get a maculopapular rash, especially in the postauricular region and the face. The 3 C's of measles, cough, coryza, conjunctivitis. Associated patient will be having diarrhea, vitamin A deficiency, and malnutrition. Important complication would be pneumonia, whereas in pregnancy it leads to congenital varicella syndrome. Here it leads to otitis media and pneumonia. Okay, done. Next, the post-exposure prophylaxis. If in case of outbreak, chickenpox, isolation is done first. Post-exposure prophylaxis should be done in 2 things. If the patient is immunocompetent or immunocompromised or pregnant. In immunocompetent patient, a monovalent strain of the exposed of the outbreak virus is done, OCA strain, within 5 days of exposure is given. If the patient is immunocompromised or is pregnant, immunoglobulins are better used. The dose is per kg body weight 12.5 units per kg body weight, and that's repeated after severe cases in 3 weeks. This immunoglobulin should be best given within 3 days of exposure or 72 hours of exposure. Okay. In measles, the post-exposure prophylaxis will be measles vaccine within 10 days almost, 11 to 12 days, and protection is almost lifelong. Administration within 3 days. If the patient is immunocompromised, you can give immunoglobulins. The dose is 0.5 ml per kg, whereas that it goes 12.5 units per kg. And extra dose of measles is given at some measles dose is starting at 9 to 12 months. You can give an extra dose within 6 to 9 months of age if there is a measles outbreak in an area, or if you're in a refugee camp, conflict zone. Daycare centers have a known case of measles case, then it's very important you can give 0 dose of measles. We have measles 1 at 9 to 12 months and measles 2 at 16 to 24 months. Measles 0 dose can be given at 6 to 9 months of age. Okay. Next we're going to see about another important disease, that is rubella. Rubella, it is also called as day 3 fever or German measles. It is a mild and self-limiting disease. So it is epidemiologically only we get 50 to 60% of cases, as most of it is going to be subclinical. The peak age would be similar to measles as it is. We have less than 3 years would be measles, whereas in rubella, German measles, the age is from 3 years to 10 years. If in developing countries, if the country is developed with better sanitation and all, the age would be more than 15 years. Incubation period, just similar to them, it's like 2 to 3 weeks. And period of communicability, in measles it was 4 days before to 4 days after the onset of rash. In rubella it is 7 days before to 7 days after the onset of rash. Complication would be, in very important complication here is that in pregnancy the patient gets congenital rubella syndrome. The baby gets congenital rubella syndrome. We have a triad of sensorineural hearing loss in the ear, cataract, salt and pepper retinopathy, glaucoma, uveitis in the eye, and patent ductus arteriosus in the heart. So this is the triad of congenital rubella syndrome, which is very important. So the trend of infection, outbreaks are seen every 6 to 9 years in case of rubella. So communication period is 7 days before to 7 days after the onset of rash. And post-exposure prophylaxis, we have rubella vaccines. Rubella vaccine is 27.3, rubella A, it's a live vaccine, 27.3 strain. Single dose rubella is given after 12 months of age, and it protects from patient from rubella. It's not lifelong protection, but it protects for almost 15 years. If pregnant females with known exposure, rubella immunoglobulins are given. Indication during outbreak. If the patient is non-pregnant and of reproductive age, avoid pregnancy 1 to 3 months after vaccination. Adolescent females, infants, it is important that you give them vaccination. So this is all about a short glimpse of rubella. Rubella, German measles or day 3 fever. It's mostly subclinical. In developing countries, the age of occurrence is between 3 to 10 years, whereas in developed countries, it is more than 15 years. Incubation period will be almost 2 to 3 weeks, and the communicability period from the onset of rash 7 days before to 7 days after. Trend of infection every 6 to 9 years, there is always new nebular cases. Important complication everyone must remember is congenital rubella syndrome, sensorineural hearing loss, cataract, and congenital heart defects, which is patent ductus arteriosus, which is most common. Rubella vaccines, a live vaccine, 27.3 strain, live vaccine strain. Single dose administered after 12 months of age. Indication during outbreaks, you are giving a vaccine to a non-pregnant female of reproductive age group. The female must be advised to avoid pregnancy 1 to 3 months after vaccination in adolescent females and in infants. Next, important thing that we're going to see about is diphtheria. So diphtheria is caused by Corynebacterium diphtherium. Corynebacterium diphtherium is a gram-positive non-motile bacteria, and it releases exotoxins. Incubation period of which will be very small, less than a week, 2 to 6 days. Presentation, mostly it is asymptomatic than symptomatic. Period of communicability would be after the onset of disease 2 to 4 weeks, almost a month after the onset of disease. Isolation criteria: until we get 2 negative throat cultures which are taken 24 hours apart, you cannot isolate the patient. You have carriers also. These carriers can be incubatory, convalescent or healthy carriers. How to prevention control? So must know the cases, the carriers and the contacts. For cases, diphtheria antitoxin is very important. Antibiotics like penicillin G is a drug of choice, or oral erythromycin can be given, and serial oral cultures 24 hours apart should be taken. When 2 cultures 24 hours apart are negative, then you can stop isolating the patient. If you see carriers, the treatment modality for them would be oral erythromycin, which is taken for 10 days in case of carriers. Or in persons of contacts, oral erythromycin is again taken, but not for 10 days, for a week almost. You're giving tetanus diphtheria toxoid vaccine. Signs and symptoms assessed. So what is the dose of diphtheria antitoxin which you are giving to the cases? The cases are examined based on the location, on the clinical presentation. If the presentation is a pharyngeal or laryngeal disease, or a nasopharyngeal disease, or extensive disease. If it's just a pharyngeal or laryngeal, 20,000 to 40,000 international units of diphtheria antitoxin is enough. If it is nasopharyngeal, from 20 to 40,000, it is 40,000 to 60,000 is given. Or if it's extensive disease, 60,000, they are not jumping, they are jumping straight to 1 lakh, 80,000 to 1 lakh is given. Okay, diphtheria toxoid vaccine indications. If you're giving more than 3 doses of diphtheria toxoid and the last dose was less than 5 years ago, there is no need to give the toxoid again. If you have given already more than 3 doses and the last dose was above 5 years, a single dose toxoid is enough. If the patient has taken unknown status, they don't know if they're taking the diphtheria toxoid vaccine, or if the vaccine is given only less than 3 doses. Diphtheria toxoid is given and complete the diphtheria toxoid 2 primary doses and 2 booster doses. This is all the treatment of diphtheria. Coronary bacterial diphtheria, we saw that, and it was a gram-positive non-motile bacteria. It releases exotoxin. Incubation period is very less, 2 to 6 days, less than a week. Presentation mostly asymptomatic. Period of communicability would be like 2 to 4 weeks, almost a month. Isolation criteria: 2 negative throat cultures 24 hours apart. Carriers to be healthy, convalescent or incubatory. Cases, diphtheria antitoxin is given and dose is pharyngeal in case of pharyngeal, laryngeal cases 20 to 40,000. If it is nasopharyngeal, 40 to 60,000, or if it is extensive, 80 to 1 lakh. Carriers को oral erythromycin for 10 days is given, and for contacts, oral erythromycin is given only for 7 days, and the patient is asked to vaccinate. Diphtheria toxoid vaccine doses. If the patient completed 3 vaccines and that is the last dose is less than 5 years, no need to give another booster. If the patient has completed more than 3 doses, you have more than 3 doses, but the last dose was given above 5 years, a single booster dose is enough. And if we have unknown status or less than 3 doses is given, then start the vaccine, 2 primary doses and 2 booster doses. Next, let us see about another important thing, which is hepatitis B. 15 to 20% of the Indian population are hepatitis B positive, which is a very, very big thing to know about. So hepatitis B virus is a double-stranded DNA virus. Of all the hepatitis viruses, hepatitis B virus is the only double-stranded DNA virus. It is heat labile and it's susceptible to hypochlorite disinfectants. The reservoir of hepatitis B virus is of course humans. Incubation period will be 1 to 6 months. Period of communicability will be till patient is HPCG positive, the patient will be communicable. The mode of transmission, important one, would be parenteral transmission. It could present either as acute or chronic conditions. The important mark is that we must know about is HPCG. If it is positive, the patient is very much communicable. The patient is an acute or a chronic infection. If HPCG is negative, the patient is susceptible, or patient is immune to natural infection, or the patient is vaccinated. Then we have another HPS and HPC. These are specific. HPS is specific, which indicates immunity is present. HPC is not specific, and that is also indicating of immunity. We have vaccines. The recombinant vaccine, hepatitis B vaccine, HBV, hepatitis B vaccine, which is an important recombinant vaccine. It is given at birth. 0.5 ml is given at left anterolateral aspect of thigh within 24 hours. That is going to prevent the mother to child transmission. In adult, 1 ml is given, and that is a lifelong vaccine. Contraindication is when the child gets an anaphylactic reaction, it is important that you stop it. Cold chain storage is very important for hepatitis B vaccine because it is freeze sensitive and should always be stored. When you are storing an ice-lined refrigerator, the hepatitis B virus will always be in the top shelf because it is freeze sensitive. You should always be storing at the top shelf or in the lowest shelf of a fridge. In ILR, in the top shelf of IR, or in the fridge, lowest shelf. We have schedule 016. If uninterrupted, you can resume it. Hepatitis B immunoglobulins. If a healthcare worker or if somebody is getting accidental needle injuries, check HPCT in HCP. If it is positive, there is no vaccination. If it is negative, the important is you give vaccination. Timing is given immediately, almost within 2 days. Dose is 0.05 to 0.07 ml per kg of body weight. 2 to 3 doses are given. Okay. The CDC guidelines for responding to HPV exposure is if the person is the healthcare worker, for example, let's take a healthcare worker. If the healthcare worker has completed the series, documented responder, there is no need of action. If documented but it's not responder, evaluate the source of exposure. If the exposure source is negative for hepatitis B, there is no need of action. But if the source is HPV positive or if unknown, then I give HPV immunoglobulin 2 doses which are 4 weeks apart. And if the response is unknown, healthcare professional anti-HPV is taken. If it is more than 10 units, there is no international unit per ml, there is no need to take any action because it's a very good amount. But if it is less than 10 international units per ml, source of exposure should be seen. Source of exposure, if hepatitis B is negative, I have to revaccinate them again, no need of immunoglobulins. But if the exposure source is HPV positive, I have to revaccinate them again. Next, if the healthcare worker has incompletely vaccinated, I have to check the source. If the source is negative, I have completed the vaccination, there is no need of immunoglobulins. But if the source is positive, I have to complete vaccination, and 1 immunoglobulin dose is very important. So the 5 C's of hepatitis B prevention is consent. There should always be consent and confidentiality, correct test results, counseling, connection to preventive treatment and care services. This is all about HPV, hepatitis B. It's 15 to 20% epidemiology is positive for hepatitis B. It is a double-stranded DNA virus, heat labile, and is susceptible to hypochlorite disinfectants. Human are important reservoir. Incubation period will be 1 month to 6 months. Period of communicability till the patient is HPV positive, he is going to communicate. Mode of transmission will be parental route is an important transmission route. Presentation could be as acute or chronic. Important markers will be HPS-AG, anti-HPS, anti-HPC. The vaccine is a recombinant vaccine. This is contraindicated in an anaphylaxis patient. Cold storage in an ice-tight refrigerator because it is freeze sensitive. It will always be stored on the top shelf, or in a normal fridge it is stored on the lowest shelf. 0, 1 and 6. This is the normal schedule. 0.5 ml iron is given at birth within 24 hours in the left antenatal aspect of time. In adults, it is 1 ml and it's lifelong. Immunoglobulins is given if there is accidental linguistic injury exposure. Okay. The dose of immunoglobulins is 0.005 to 0.07 ml per kg body weight, which is given in 2 to 3 doses. The guideline for responding to HPV exposure if the series is completed or if incomplete vaccination. Incomplete vaccination, documented respondent, there is no action. Documented but it's not responder, evaluate the source of exposure. If it is negative, no need of action. But if the source is positive, immunoglobulins can be given 2 doses, 4 weeks gap. Or if the response is unknown, healthcare professionals anti-HPS is taken. If it is more than 10, there is no need to worry. If it is less than 10, you have to worry about the source. Source is negative, you have to revaccinate the exposed patient. Or if the source is positive, revaccinate and also give 1 dose of immunoglobulins. If there is incomplete vaccination, source is negative, complete the vaccination. If the source is positive, complete the vaccination and also get 1 dose of immunoglobulins. Okay. Next important soil transmitted helmintic infections will be tapeworm and hookworm, Ascariasis and Ancylostoma duodenum Licata americanus, Ascaris lumbricoides. The worm is tapeworm, 15 to 30 centimeters long, whereas hookworm is a very small worm. It is 10 mm, almost 10 mm, 1 centimeter, which is here it is 15 to 30 centimeter. Infective form of a tapeworm would be egg, whereas in hookworm it is always a larva. The transmission would be ingestion of this contaminated thing, whereas hookworm penetrates your skin and travels up the body. The soil would be hard and clayey soil in case of tapeworm, whereas in hookworm is seen in soft and porous soil. Hookworm most commonly causes anemia, whereas tapeworm causes diarrhea. Chandler's index is very important, you must know, which is the number of hookworm X present per gram of soil. The number of hookworm X which is present per gram of your stool is known as Chandler's index. Chandler's index is calculating the infective rate of your stool. The number of hookworm X which is present in your stool. So, National Deworming Day is 10th February and 10th August, twice a year, biannually. In the dose of deworming is in adults we're taking 400 mg, and in children, which is less than 2 years of age, 200 mg is given. Prophylaxis for hookworm infection. And Chandler's index, if it is less than 200, it's not a public problem. If it is between 200 to 250, it is a potential problem. 250 to 300 is a minor problem, and above 300 it's a major problem. So remember, Chandler's index above 300 is always a major problem. Chandler's index is nothing but number of hookworm X in your gram of stool. Okay. Rabies. Rabies is a RNA virus, a single-stranded RNA virus of Rhabdoviridae family. The virus is bullet-shaped. There are two types of viruses, fixed virus and street virus. The fixed virus is used in axil formulation. Incubation period will be 6 days, whereas the street virus causes the actual disease and the incubation period is variable. It could be days to years, just like a child. The categories of animal bite, we have this is an important thing, categories of animal bite. Categories 1, 2 and 3. Category 1, on an intact skin, the animal touches, licks, feeding or touching animal licks, nothing but. On category 2, on an uncovered skin, the animal is nibbling, or you have minor scratches or abrasions. There is no bleed, but there is a minor scratch or minor abrasion. That is category 2 exposure. Category 3 exposure, there is single or multiple transdermal bites, scratches and bleeding, contamination of mucous membranes or broken skin with saliva from animal licks, exposure to direct contact or to wild animals. This is category 3. Category 1, you having a healthy skin, intact skin, the animal just touches, feeds or licks. Category 2, on uncovered skin, nibbling of the animal or minor scratch, minor abrasion, there is no bleeding. Important point, there is no bleeding in category 2. In category 3, there is bleeding, there is a single or a multiple transdermal bite or scratches, contamination of mucous membrane or broken skin. Okay, this is wound management is done for all the three things. ARV is given for category 2 and category 3, and rabies immunoglobulin is given only for category 3. Okay, the prophylaxis first, wound management should be done for all the exposures. Wash with soap under running water for 15 minutes. Delay sutures, even until 24 hours you can delay the suture, clean the area and then you can suture it. Prophylaxis, post-exposure prophylaxis is very important. Indication, all wild animal bites, all pet animal bites is an important thing you give post-exposure prophylaxis. It is not given for the following infected sources. If it is a human bite or a bat, small rodent like squirrels and rats, insect, drinking milk from the cattle, these things does not need a post-exposure prophylaxis, but you need it for all wild animal and pet animal bites. It's not needed for bats, rodents, insects and cattle milk. So you have two regimens, Essence regimen, modified or updated Thai Red Cross regimen. Essence regimen says that you have to give the vaccine at 0, 3, 7, 14 and 28, which is within a week 3 doses, and the second week and after a month. In the first week I am giving 0, 3 and 7. These 3 doses are given in 1 week, and after 1 week on the 14th day I am giving a second dose, and after 1 month after 28th day I am giving the last dose. Just 5 doses are given. This is all IM, 1 dose per visit. Whereas the modified or updated Thai Red Cross regimen says 0, 3, 7 and 28. And this is the regimen of modified Thai Red Cross regimen. It is given intradermally, 2 doses per visit. So number of visits is just 4 doses. Okay. The pre and re-exposure prophylaxis is given either an IM dose or intradermal, because Essence says you have to give an Essence regimen, says it is given as intramuscularly. Modified Thai Red Cross regimen says it can be given intradermally. The pre-exposure prophylaxis regimen will be 0, 1 week, 3 weeks and 4 weeks, 0, 7, 21, 28. Re-exposure prophylaxis, there is no need of rig, 0 and 3 days is enough. Indication for re-exposure prophylaxis, patient is previously immunized. Last vaccine was 3 months ago. So prophylaxis is given. Re-exposure, 2 doses. Pre-exposure, 3 doses. Updated Thai regimen, 4 visits and 8 doses intradermally. SN regimen, 5 visits and 5 doses. Rabies immunoglobulin. Within 7 days of exposure, it's not given for re-exposure, immunoglobulin is not needed. But for exposure in 7 days, it's given. We have 2 immunoglobulins, equine rabies immunoglobulin, human rabies immunoglobulin. Human is half the dose, just 20 internationals per kg and is safe and efficient. Whereas equine is double the dose, 40 internationals per kg. The route is maximum is infiltrated in and around the wound, and the remaining is given IM at the nearest site. So remaining rig is given IM in the nearest site. The maximum rig is given in and around the wound. Next, let's see about this is all about rabies. Rabies is caused by a Rhabdoviridae virus. Rabies virus, single-celled RNA virus, it's bullet shape. We have 2 types, fixed and street type. Categories of bites, we have category 1, 2 and 3. We had exposures. Important regimens are SN regimen, and we had modified or updated Thai Red Cross regimen. SN regimen had 5 doses, 0, 3, 7, 14 and 28. Whereas modified updated Thai Red Cross regimen had 0, 3, 7 and 28. Pre-exposure, post-exposure prophylaxis for rabies immunoglobulin. Okay. Next, it is about tetanus. Tetanus, the post-exposure, it's always, anytime you're getting any infection or any abrasion, injury, it's important that you get a tetanus vaccine because the post-exposure prophylaxis is very important. In a clean wound, sterile instrument injury brought in 6 hours, we have categories A, B, C. The full tetanus immunization was done within 5 years. Only wound care is enough. The immunization was done within 5 to 10 years, wound care and a single dose is important. Full immunization was done more than 10 years ago, wound care, a single dose, or if the wound is unclean, wound care, a single dose, and immunoglobulin is given. And the patient has never been immunized or the patient doesn't know, then you have to complete the TT dose. And if the wound is unclean, you have to give immunoglobulins. Then we see about rickettsia, short gist. Rickettsia group causes a lot of diseases. First, let's start with endemic typhus and epidemic typhus. Endemic typhus is caused by Rickettsia typhi. Endemic typhus, Rickettsia typhi. Epidemic typhus is caused by Rickettsia prowazekii. That's it. Scrap typhus, as we all know, it's called Rickettsia or Orantia suzukamoshi. Then, Q fever by Coxiella burnetii, trench fever by Bartonella quintana, rickettsial pox by Rickettsia accarni, Rocky Mountain spotted fever by Rickettsia rickettsii, Mediterranean spotted fever by Rickettsia conuri. Okay. This endemic typhus, Rickettsia typhi, is caused by a flea and reservoir will be rodent. Epidemic typhus by Rickettsia prowazekii is caused by louse. Scrub typhus is caused by mite and that reservoir is rodent. Trench fever, louse, and it's human. Q fever, mostly none of ticks. It can come by a sheep, cattle, and goat. Rickettsial pox is caused by a mite staying in mice. Rocky Mountain spotted fever is tick. Mediterranean spotted fever is again tick, which is caused by Rickettsia coronari and Rickettsia rickettsii. And last, we're going to see about Naegleria fowleri, which is a thermophilic free-living amoeba. The amoeba from water, it causes infection in your nose, warm freshwater bodies, or inadequately disinfected pools. This Naegleria fowleri is seen. It's a free-living amoeba, especially in freshwater bodies. So it has got stages: trophozoite stage, which is active infective stage, and it's only found, the only stage which is found in humans will be the trophozoite stage. And then cystic and flagellate stages are temporary, but it's not found in humans. The clinical features would be the patient would be having nausea, vomiting, neck stiffness, fever, seizure, photophobia, altered mental status. Diagnosis is by polymerase chain reaction and CSF Wetmore microscopy, because neck stiffness, seizures, photophobia, altered mental status, these are important CS symptoms. So CSF Wetmore microscopy is very important. The management is by amphotericin B, the drug of choice for this amoeba, rifampicin, miltefosine. Symptomatic management of increased ICP should be done for meningitis. This is all about Naegleria fowleri. Naegleria fowleri is a fresh water seen free living amoeba. It's thermophilic. From your nose, from the freshwater bodies or inadequately disinfected pools, you're getting infection. Trophozoite stage is the active and infective stage. It's only found in humans. The other stages would be flagellate and cystic stages. The important clinical features are it is causing CNS symptoms as compared to fever, nausea, vomiting. That is neck stiffness, seizures, photophobia, and altered mental status. So the diagnosis is by polymerase chain reaction and CSF Wetmore microscope. Management is by amphotericin B, and you can give rifampicin, mifepristone. Symptomatic management of meningitis or raised ICP should also be done.